what we have in terms of concept. You guys can interject or you don't have to if you want to add your voice to this. So mean arterial pressure is equal to cardiac output times total peripheral resistance, which some books will use systemic vascular resistance. It's the same thing. It all deals with resistance. All right, so resistance has a relationship to the radius. So it's to the fourth power, but they're opposite one another. Now radius, our goal with any of these that we have on the side is vasodilation. So we're going to take a look at which factors would assist with vasodilating in hypertension. So I'm doing this for you guys and then doing it for the video as well. So let's start off with hypertension. And then we have heart rate times stroke volume. Stroke volume is end diastolic volume minus end systolic volume. And then I have three factors that can affect these: contractility, afterload, and preload. Preload is affected by how much I'm filling the heart with. So it's otherwise known as venous return. And factors that affect venous return affect preload and ultimately blood pressure. So we're going to say mean arterial pressures is equivalent to saying blood pressure. Now, heart rate, let's start off with the simplest one. Let's say hypertension. So hypertension also means high blood pressure. Hopefully, if you guys are watching this video, you guys are going to be able to see. So I use diuretics, ACE inhibitors, ARBs, beta blockers, calcium channel blockers. What does that mean? So you guys, I'm going to slow down. Heart rate can be affected by four things. So when you talk about what we call antiarrhythmics have four general classes. They have class 1, class 2, class 3, and class 4. So when it comes to memorizing these, the fastest way to do it as a review is the first one is like the start of the letter N. So we start off with sodium channel blockers. Second class, second letter in the alphabet is B, right? So B, we start off with beta blockers. C, or not C, 3. 3 has 3 strokes in the letter K, so we say potassium blockers, right? And then the last one, 4 characters. This is class 4. 4 characters in calcium, Ca++. So calcium channel blockers. The 2 that we use for hypertension are actually class 2 and class 4. Beta blockers, this is a review. I'm going a little bit fast because I have other videos that you guys can catch up with. So I have Olol. Olol are beta blockers. What are the 2 types of beta blockers? There's one that's selective and one that's non-selective. So selective, what letters? A through M. What about non-selective? N through Z, right? So if they made a letter or they made up a drug that started with the letter Z, I'd know that it was non-selective. Selective versus non-selective. If I look at a patient that comes in that has asthma, what is the problem with giving a beta blocker that is non-selective? You might induce asthma, right? So you might trigger asthma because beta-1 blockers, if they're not selective just for beta-1, can block beta-2, and beta-2 is found in the lungs. Okay. So next one, and then we'll go slow after I finish mapping this out. So calcium channel blockers. What are the calcium channel blockers that you guys remember? Vadin. So what is Vadin? Verapamil, diltiazem, and nifedipine. But the problem with nifedipine is not the heart. It does not affect calcium channels inside the heart. It does affect calcium channels inside of the blood vessels we'll get to in a second. So high blood pressure, if I block heart rate, it slows down. If I slow heart rate, what happens to cardiac output? Goes down. Mean arterial pressure goes down. Blood pressure goes down. And that's how blood pressure regulators like beta blockers and calcium channel blockers work. So beta blockers block beta receptors in the heart. Calcium channel blockers just block the calcium channels that would stimulate the heart. So in effect, if I give you verapamil, what does it do to heart rate? Slows it down. What does it do to cardiac output? Slows it down. What does it do to mean arterial pressure? Slows it down. What does it do to blood pressure? Slows it down or lowers it. So that's how blood pressure antihypertensives will work on heart rate. Let's see how they work on something like vasodilation. So if I have ACE inhibitors, beta blockers, let's do calcium channel blockers. This is not the entire list. So when you look at this, this is a simplified list because we can fill this in, right? Let's fill this in a little bit more beyond what's on the list over there. What do I have that are sympathetic receptor antagonists? Sympathetic receptor antagonists. Alpha-1 blockers. Very good. So I have alpha-1 block. And what is the suffix for alpha-1 blockers? Docin, right? So we're going to fill in that list a little bit extra. If I have an alpha-1 blocker, what would I do for alpha-2? I would stimulate alpha-2. So I can stimulate alpha-2. What are the two drugs that stimulate? Methyl-dopa and clonidine. Not commonly used, but we do need to know that they exist, right? And then what else do I have? So I did alpha-1 block. I did alpha-2 stimulation. What from that list can I add into vasodilators? So we did, we could do parasympathetic, but I don't think they have any drugs that they've created. But what about these guys? What from this list could I use over there? Calcium channel blockers. So I can use CCBs, calcium channel blockers. What are the three? Verapamil, diltiazem, and nifedipine, and the mnemonic is Vaden. So Vaden, verapamil, diltiazem, and nifedipine are all calcium channel blockers. Diltiazem and nifedipine. The suffix nifed or dipine tells me that it's a calcium channel blocker for blood vessels. So if I replaced it with something similar like amlodipine, then I know that it was a calcium channel blocker. What else can I add here? ARBs, right? I can use ACE inhibitors and ARBs. ACE inhibitors, give me the suffix for ACE inhibitors. Pril, and give me an example of a prototype drug. Lisinopril is a good one to use, but captopril was one of the original drugs, but lisinopril is more commonly used. It's a newer drug, so it's more specific, has better outcomes. And then what about the next one that you said earlier? ARBs. Zartan, right? Zartan. And give me an example. Losartan, yeah. So we can say losartan. Losartan is an ARB. And what happens is these two, I'm not doing the pathway. So the pathway would take me even longer to try and do this. So ACE inhibitors actually reduce angiotensin 2, which is a potent vasoconstrictor. So part of their pathway stops the effects of angiotensin 2 on the receptors to reduce constriction of blood vessels and cause vasodilation. So what else do we have? We can do renin blockers, right? So our list is much longer than what's on there, but this is probably a little bit more extensive than you need to know. So renin blockers. Tecturna is a brand name. Aliskiren is one that you guys probably will not even worry about knowing. It's just extra. What else do we have? We could use nitroglycerin, but in terms of hypertension, nitroglycerin is more specific for what? MI or angina, right? So angina and MI, yes, it's a vasodilator, but we're going to keep that with the other two. What else can we use? Hydralazine. So we call these direct acting. So direct vasodilators. Mechanism, not quite understood. It's not as clear, but they memorize it, hydralazine. And then we'll stop at that list. What else do we have? So we didn't do diuretics. We have to do diuretics. We checked off ACE inhibitors, ARBs, beta blockers, and calcium channel blockers. And then on top of that, of course, we are overachievers, so we went beyond, above and beyond. For diuretics, how do diuretics work? Yeah, so they bring down preload. So this is where it happens. So if I reduce the amount, yeah, so diuretics go here. What are the diuretics? Go from weak to strong. Lasix is strong. Oh. So Lasix, that's okay. Lasix is strong. Furosemide is the generic term for Lasix. What else do I have? HCTZ, hydrochlorothiazide. Hydrochlorothiazide is a weak diuretic that they add to a lot of other drugs in combination. What else? Loop. Well, this is loop. So Lasix is an example of a loop diuretic. We did hydrochlorothiazide, which is a thiazide diuretic. And then the last one I just heard, potassium-sparing diuretic. Spironolactone is the typical one that you will hear, but probably not the one that's commonly used just because the side effects. OWN means that it is a steroid. Steroids in men will cause boobies. What are boobies called? Gynecomastia. So that's one of the side effects with spironolactone. They have other ones like, I'm just going to write it down, it's overachieving. Triamterene. Triamterene is a potassium-sparing diuretic. Doesn't have the OWN in it, so you know it's not steroid-based. And how does that work? Diuretics reduce preload. How? Well, because you pee it all out, you reduce blood volume, you don't have enough going back to the heart, that reduces preload, that reduces EDV, reduces stroke volume, reduces cardiac output, reduces venous arterial pressure, reduces blood pressure, right? So let's go back to this. How does this reduce blood pressure? Well, all of these cause vasodilation. If I vasodilate, the radius becomes bigger, the resistance becomes smaller, TPR goes down, mean arterial pressure goes down, and blood pressure goes down as well. So this is a really great way that you guys have already memorized to do this. Good, okay, so let's erase all of this. That was hypertension. Let's go straight to the next one. So let's do the one on the right, congestive heart failure. Probably easier for us to go through that. And then we're gonna jump to these because if you notice there's matching between what drugs that they use for stable angina and unstable angina or even MI. Woohoo! Oops. Nice to be able to predict all of this. Okay, what is CHF? Congestive heart failure. Heart failure in general is when the heart fails to produce enough pressure to move blood out of the heart. I know, I want to say my mnemonic. My way to remember blood, or at least the function of the heart, is to generate pressure to overcome resistance to drug flow. If it can't do that, it's going to fail on you. If I can't get blood flow to the brain, then I'm going to have somebody that is weak, tired, going to pass out. If I can't get blood flow from the heart to the kidneys, I might have kidney failure. So the heart really is important. How do we manage congestive heart failure? So I've done this diagram many times with you guys, and I say that there is right side of the heart, left side of the heart, and there's blood that flows into the right side and blood that flows into the left side. So the right side of the heart versus the left. Body goes through the vena cava into the right atrium, the right ventricle, out through the pulmonary arteries, to the lungs, through the pulmonary veins, into the left atrium, left ventricle, and out through the aorta. If I damage the left side of the heart, I have left-sided heart failure, then where is blood going to back up into? Left for lungs. So anytime you see left heart failure, you know that the symptoms are going to be in the lungs, left for lungs. So what are the symptoms that are associated with left heart failure? Difficulty breathing, shortness of breath, and dyspnea, right? All associated with what? Pulmonary edema, pulmonary congestion, pulmonary edema, and difficulty breathing because I can't get oxygen across that water. So now, how do I deal with it first? Diuretic. Okay, so there's two big drugs that I'm going to use for heart failure. The first one is a diuretic. And why a diuretic before something that increases its strength of contraction? Yeah, so it reduces the amount of load on the heart. So the problem is, if, let's say that these, I'm going to do this to the, no, okay. So let's say that there's overlap, right? And this represents strength of contraction. If this overlap is reduced to the point that there is no overlap and I can't grab, then the heart itself is weak. So if I try and increase strength of contraction, it's like grabbing a big water balloon and then having two of your friends help you. It's not as effective as opening the top of the water balloon and letting some water out before you squeeze it. So the diuretic acts to open up the water balloon and let out some of the water. And your friends act as what we call digoxin to increase the strength of contraction to help move the rest of the water or fluid out of the heart. So let's go over left-sided and then let's do right-sided before we move on to the drugs. So we said left-sided heart failure leads to the lungs. What about right-sided heart failure? Yeah, right. The letter R almost looks like the letter B, so right for body. Right heart failure leads to symptoms in the body. What symptoms are they? Edema, right? So all of this is edema. Congestion leads to edema. Edema where? In the legs. Why in the legs more so than the arms? Because gravity helps to compound, I guess, the pressure that's pushing down on the legs or on the fluid that's in the legs. So let's erase this. So we know left leads to lungs and right leads to body. So both of them are going to be associated with edema. Well, CHF, yeah, let's say CHF, but also edema. And so I have to remove the water first, and then I can give what? Digoxin to help increase the strength of my contraction from the heart. So let's see how. Why loop diuretics? Why not just a weak diuretic like hydrochlorothiazide? Is heart failure an immediate problem? It's an immediate problem. Hydrochlorothiazide is a weak diuretic to help ease pressure over time. Whereas loop diuretics, it's quantity based, so you can give more and more and more to induce more diuresis, which means more removal of blood, okay, or at least blood volume. So preload is affected by diuretics. We did this already. So what diuretics are we going to use for congestive heart failure or heart failure? I'm going to use Lasix because this is the most powerful. So Lasix is a loop diuretic, also known as furosemide. You notice there's a lot of overlap between all of these drugs. What else do we have? So I use my diuretic. That one's done. What else do I want to give? Digoxin. So after I remove the fluid, I want to make sure that the heart is working hard. The heart has health and it's able to squeeze harder to get more blood flow out. So it deals with what we call contractility. Contractility, digoxin. How I remember digoxin is digifab, digitab, digimod. One of those is not right. Okay, so, sorry guys, yeah, this is me. Digoxin, how does it work? So, for you guys, just memorize that it increases calcium levels. It is actually an inhibitor. It blocks sodium potassium ATPase, and that blocks the secondary active transport, which normally would exchange sodium going in for calcium moving out. If I block all of that, sodium can't go in, calcium can't go out, calcium gets stuck in the cell. So now the next time I have a contraction, because there's so much calcium inside of the cell, it makes the contraction much stronger. That's really how it works. You don't have to know that. So calcium, and I'm going to say this and this match more evenly. So we're going to skip these two guys. We're going to say contractility. If this goes up, what happens to stroke volume goes up. But in the case of a patient, so don't look at the blood pressure, because in the case of a patient that has heart failure, none of this is working right. So we're not even going to look at how it affects blood pressure. We're just saying the heart is not working right. It's weak. So my goal is to make sure that it's stronger. Cardiac output represents the heart strength. So if the heart is working well, it's going to have an efficient cardiac output. Okay, so my goal is to just make sure that the heart is back to normal. So if all of this is going back to normal, but let's say that I don't want the heart to fail again, so I want to reduce how much or how hard it works. Not necessarily how strong it contracts, but how hard it works. Would I want heart rate to go faster or slower? I want to slow it down. So we have other drugs like beta blockers. And beta blockers are what class of antiarrhythmics?
Two.
Class 2. So class 2 antiarrhythmics like beta blockers will actually reduce heart rate and reduce the oxygen demand of the heart so that it's not overwhelmed again and it doesn't go into heart failure. So beta blockers would do what? Would do what? They would decrease heart rate. And give me an example of beta blocker suffix. Olol. And what are the ones that are associated with beta 1 selectivity? A through M. So if I gave you atenolol, I gave you metoprolol, I gave you propranolol, and I gave you zalanolol. Which one of those is beta 1 selective? Atenolol and metoprolol. Which one is non-selective? Yeah, the all, and then the propranolol. So which one would you consider using with a patient that might have asthma? Atenolol and metoprolol. Very good. What else do I have? So I did this, I did this, I did this. ACE inhibitors help with reducing afterload on the heart. So afterload technically can relate back to your vasodilation. So how much the heart has to work against can be affected by afterload. But we'll put this under vasodilation. How do ACE inhibitors work? We only did one associated with vasodilation. It can work multiple ways, right? It reduces the amount of angiotensin 2, which normally would cause vasoconstriction, but because I'm blocking it, causes vasodilation. Right? So if I vasodilate, radius goes down, resistance goes down. Basically, the workload of the heart goes down. So it decreases oxygen demand again. So we'll stop at that. We did hypertension, we did CHF. Let's do the overlap between stable angina and unstable angina. Ooh, good. We're on time. We'll finish this off in 5 minutes and then go over other stuff. Okay, what is angina versus unstable angina versus MI or STEMI? Yeah, so angina itself
is associated with decreased oxygen flow.
Yes. So angina, chest pain. Stable angina means maybe somebody over 40 years, 50 years ate a lot of cholesterol or ate a lot of fat, which led to an increase in cholesterol, which led to deposition of fat into the arteries. So now the arteries are narrowed, more narrow than normal. So angina occurs when there's a lack of blood flow to the area, maybe not completely obstructed, but decreased. So when they're resting, they're fine. As soon as they work out and they increase oxygen demand by the heart, then the heart will trigger release chemicals that say, ouch, I'm hurting, I need more blood. What would happen with stable angina versus unstable and STEMI though? So stable angina, if you rest, you can recover from like that experience of pain with the chest. Or if you give yourself nitroglycerin, which is a vasodilator, you can alleviate the symptoms. What about unstable angina and MI? What's the problem with those? You can't relieve the symptoms, right? So you can't relieve it by rest, you can't relieve it by changing position, you can't relieve it by using nitrate. One of the problems with unstable angina and MI is that there's an occlusion typically by a clot. So now we have to deal with the clot. If you give nitro and it's not alleviating the problem, then you know something else is wrong. That's when you go into the emergency room. How are they different? How are they similar? Well, they can both lead to an MI. So unstable angina, the tissue is not dead yet. STEMI, ST elevation MI, MI stands for myocardial infarction. Infarction means necrosis and tissue death. So the difference between these two is that the cells are not dead yet, and the cells are dying. So there's some cardiac markers that are associated with cell death. But unstable angina can lead to an MI, because if you don't deal with the clot, then you're going to end up with tissues that are dying off. How do I deal with the clot first? So that's the first thing. So there is, wait, before you guys answer that, There's the mnemonic. You notice this is just a generic list, right? Here's the mnemonic. And how does that mnemonic associate with somebody that's having an MI experiencing at home? What's A? What do you give? Well, it's the first thing you give at home. Aspirin. You don't know what you have, but you think you're having a heart attack. You give aspirin at home. How does aspirin work? It's an anti-platelet. It stops platelets from continuing to form. So it doesn't break up the clot, but it manages and reduces the clots from compounding. What's the next thing you give? As soon as you get into the hospital, you might give oxygen and nitroglycerin, right? Let's choose oxygen first. Let's say that's the first thing I'm going to give him oxygen because he's not breathing well. So I give O2 and then I can give nitroglycerin. How does nitroglycerin work? Yeah, so I'm going to put nitroglycerin under vasodilator, right? Nitro is going to be over here. But the thing is, although it's going to reduce blood pressure, the goal is to actually vasodilate where? Yeah, so I'm trying to vasodilate coronary arteries so that I can get blood flow directly to the working muscles of the heart. Now, what is M? Morphine. So morphine, and this is, these are drugs that you're going to give in the event of having an MI or unstable angina. You're going to give that to ensure that you're managing the clot, right? So I give morphine. What does morphine do? Morphine is for pain, but it's also a CNS depressant. So it reduces anxiety as well. So in addition to dealing and managing the pain, it reduces oxygen demand by the heart because it slows the heart down. You don't have anxiety. Your heart rate goes down as well. How do I deal with the clot? Remember I said that this was all because of a clot that's blocking its way. How do I deal with the clot? I break it, right? So either I can use a drug. Let's say that I don't have a cath lab and I can't get a catheter in to use a stent to crush the clot. How can I deal with it pharmacologically? I can use TPA. TPA is alteplase. TPA alteplase. So alteplase is basically your clot buster. Breaks up the clot. If I do have a cath lab, they're likely to send you down to put a stent in. The stent that they might put in, or at least the procedure that they call it is a PCI, percutaneous intervention, and it's basically just a stent with so you use a cath, and then you put in a stent to open up and crush whatever's there. How do I manage unstable angina, MI, and stable angina post-event? Okay, maybe I use blood thinners to ensure that, right, aspirin, daily aspirin, or if daily aspirin is not working, you can use blood thinners, right? We're going to say blood thinners for now. What else can you do? So we got aspirin. Aspirin is going to reduce. Bring down cholesterol, okay. Statins is the most effective at reducing LDLs. Statins like Lipitor, right, atorvastatin. What else can we use? So all of these are to help to reduce blood pressure too, right? So reducing blood pressure means I can help with reducing the future events. So nitro is used when? Typically, when is it used? In emergency. So you have it on hand just in case you have another event in the future. Okay, so we got that. What else do we use? ACE inhibitors, right? So ACE inhibitors work the same way. It's vasodilator. It's not the only thing, but we're going to classify it as vasodilator. It's the fastest one. So vasodilator, ACE inhibitors, ARBs if ACE inhibitors are not tolerated well. And then what about B? Beta blockers to reduce the demand on the heart. And it also helps with reducing blood pressure. And then CCBs, how do CCBs work? It depends on which one you use, right? It reduces calcium. So we said calcium channel blockers are class
2 and 4.
2. Well, 2 is beta blockers. What about calcium channel blockers? They're class 4. How do you remember? 4 characters in CA++. So calcium channel blockers, which ones are associated with the heart? Verapamil and diltiazem, and not nifedipine. Where does nifedipine work? Over here in vasodilation, right? Verapamil, diltiazem, and nifedipine all work on vasodilation. So it just depends on which one you're going to use. So if you're using a beta blocker, maybe you can use something like nifedipine, because nifedipine will deal with vasodilation there. And then if you have reflex tachycardia, then beta blockers will slow down heart rate. Okay, so that is as simple as it gets. Bye-bye.